Okay. Good afternoon, everyone. My name is Will. I'm a rising fourth-year medical student at UC San Diego. My mentor is Dr. Sam Eisenstein from the Division of Colon Rectal Surgery, and I want to also take a moment to acknowledge all of our collaborators at other sites. So today we're going to be talking about delayed versus immediate pouch formation in restorative proctocolectomy for patients with ulcerative colitis. So a little bit of background. So ulcerative colitis is a chronic, relapsing and remitting autoinflammatory disease of the large bowel. And as it currently stands, surgery remains the only curative modality for this disease. And in order to get rid of the disease, you need to remove the diseased colon and rectum. And a popular procedure for this is called a restorative proctocolectomy with ileopouch anal anastomosis. And essentially what this is you remove the disease section of the large bowel. You take the remaining terminal ileum and you make a J pouch here, an ileopouch, and you anastomose that to the anus with the end result of hopefully preserving the patient's native continence moving forward and avoiding the need for a permanent ostomy. Now, the good news with ulcerative colitis is that in the past decade or so, big strides have been made in medical management of this disease and essentially allows patients to delay surgery longer and maintain longer quality of life before they need to come to the operating room. The downside is that once patients fail all these advanced therapies, they still need to come to the operating room and are a lot sicker on presentation nowadays than they were about 10 years ago. The case in point is that medications currently still cannot cure ulcerative colitis. They only delay the inevitability of surgery. So when faced with these sicker patients, surgeons have come up with a technique of delaying that pouch formation that I showed you earlier. Whereas previously, patients would get their pouch immediately at the first surgery with a total proctocolectomy, now surgeons are starting to delay this pouch formation until a second surgery several months after an initial subtotal colectomy. And the reasoning behind this is that this allows the patient to have a few months off of these heavy immunosuppressants, a few months to gain more weight, get better nutrition before they come back for that critical ileopouch anal anastomosis. Because if you're malnourished and you're on heavy immunosuppression, you're less likely to heal that anastomosis properly, and that can lead to a lot of nasty outcomes. With that said, so this is, as you can see, this is a very complicated procedure. It can involve one or two or even three stages. And when you want to do a retrospective study on this kind of procedure, you have to rely on registry data, which unfortunately lacks, as it currently stands, lacks a lot of IBD-specific variables. And the big database that we're focusing on for this talk is NSQIP, or the National Surgical Quality Improvement Project, run by the American College of Surgeons. And again, this makes studying predictive factors for allocating patients to these different surgeries, as well as their outcomes, a difficult task when you don't have the variables that you need to analyze these outcomes. So to bridge this gap, UCSD and other colorectal surgeons from other sites formed a NSQIP Inflammatory Bowel Disease Collaborative. And here are all our collaborators here. And essentially what they did is, starting in 2017, they took existing NSQIP data and added, I'm so sorry, and added these novel IBD-specific variables that you see here. And with that in mind, what we did for this project is we took that new database, 2 years of data, and we asked the following questions. First, what predicts a surgeon's decision to delay IPA formation for a patient? And the second one is, once you've delayed a patient's pouch formation, do they have better postoperative outcomes than patients who had immediate pouch? And to answer these questions, we described current trends in delayed pouch formation and whether any of these result in differences in complication severity using our novel IBD-centered surgical database. So to start off, we first had to classify these procedures, which proved to be pretty challenging with using retrospective data available. First, we had to take patients with an ICD-9 or 10 diagnosis of ulcerative colitis from our database and combine that with CPT coding, which is essentially a way insurance companies or a way that healthcare providers bill for procedures. And then on top of that, we added anastomotic technique and ileostomy formation. That was collected in our novel database, and we grouped patients into one of three groups. The first group was index surgery for immediate pouch, so this is people who had their total proctocolectomy with pouch up front. The second group was patients who received their index subtotal colectomy with the assumption that they will return at a later time for their delayed pouch. And the third group were those patients who did end up returning for that delayed pouch formation after their subtotal colectomy. And so a quick rundown of the data that we collected. So just under 800 patients with ulcerative colitis between March 2017 and March 2019, 46 of whom received upfront pouch formation with total proctocolectomy. 266 of these patients received their index subtotal colectomy in preparation for an eventual delayed pouch, and 118 received their completion proctectomy and their delayed pouch after their initial surgery. So analysis was performed using SPSS. For predictors, I took baseline preoperative demographic variables like age, gender, comorbidities, BMI, malnutrition, and whatnot, and put them into a model to predict for what kind of things drove surgeons to delay pouch formation. And then a second analysis was to look at an adjusted analysis of Clavien-Dindo score. And the Clavien-Dindo score is a quantitative method of grading how severe a patient's complication profile was in a 30-day postoperative period using all of these outcomes here that are tracked in both NSQIP and our database. And I use the backward selection model, starting with a univariable analysis to enter into our multivariable analysis. Some results. So baseline characteristics. From the get-go, if you compare patients with the index subtotal colectomy with patients who got their pouch up front, you can see here that patients who are having their pouches delayed were more likely to be taking immunosuppressants. They're more likely to have preoperative weight loss and malnutrition, and they also tended to be performed at higher volume centers that might see more acute cases or have more experience with performing delayed pouches. And in contrast, patients who are returning for their completion proctectomy for their eventual delayed pouch formation were actually less likely to be on steroids and biologics. And that makes sense because this is a patient population that has essentially been weaned off these heavy immunosuppressants and are now healthier and returning for that critical pouch formation stage. So here's our multivariable analysis for predictors of pouch delay. Big one here is ulcerative colitis surgery case volume is a very strong predictor. Sites that performed the upper quantile of cases were about 3 times more likely to be performing delayed pouches. Another thing to point out is that patients with colonic dysplasia, including colorectal cancer, were actually more likely to have an immediate pouch rather than a delayed pouch. And my thinking behind that is these patients might actually be healthier when it comes to their ulcerative colitis, but they still have colonic dysplasia nonetheless. So for predictors of our post-op complication severity, the big takeaway here is that patients with a worse ASA classification, which is a measure of how sick they are when they enter the OR, are more likely to have worse complication profiles once they leave the operating room. And that makes sense. If you're sicker when you enter surgery, you're going to probably do a little bit worse than your counterparts outside of surgery. Other things to focus on. So procedure time as well was a predictor for worse complications, mainly because longer operations expose patients to more intraoperative risk. And so with that, moving into our discussion. So this study has limitations like any study, the main one being that this is still a retrospective registry. Despite having the luxury of larger sample sizes, there's always surveyor bias and observer bias when it comes to retrospective registries that you need to think about. Ideally, a prospective observational cohort study would be the best kind of thing to run for a research question like this, but in the current literature, those studies are limited to small single-center projects. And with that said, our retrospective registry is still pretty small because it's only 2 years old. And our IBD component is still maturing, meaning that we are still working on coming up with new variables to add to the database. But with that said, we're hopeful that as the database matures, we are going to be able to collect more and more granular detail to focus on this population that relies so heavily on surgery for both improving their quality of life and for curing their disease. And so taking together, what does all of this mean? So luckily, delaying pouch formation is not an independent predictor for worse complication profile. But with that said, it's also not an independent predictor for better complication profile. And what that means is that surgeons are likely allocating patients to a delayed pouch as opposed to immediate pouch only when necessary. And the take-home point here is that surgeons should continue delaying pouches with patients who are showing up with heavy immunosuppression, malnutrition, and with essentially just more advanced disease. And again, you don't want to delay that pouch when it's unnecessary. And the bigger picture here is that this collaborative and its work highlights the fact that with a concerted effort, you can get disease-specific variables that allow for much more granular analysis than what was previously available using ACS NSQIP. And things that I'd like to try in the future is to compare sepsis rates, especially secondary to anastomotic leak, because this is the most feared complication from anastomotic failure. Right now, our event rate is pretty low because of our small sample size, but the third year's samples are just starting to come in, so hopefully we'll have more patients to do analyses on. Long-term quality of life follow-up is always important to consider the patient's perspective. We only have outcomes tracked out to 30 days post-operative at this point, so in the future, the hope is to be able to survey patients more prospectively moving forward. And one thing to highlight is that, I've mentioned this earlier, but relying on billing codes for the purposes of research can be very difficult. Billing codes don't always accurately reflect the complexity and the multi-stage approach to these big procedures. And moving forward, when we're doing registry data and registry research, we might have to come up with some better ways to categorize these procedures. And thank you all very much.
You've done a terrific job with this observational approach, and I understand its limitations. I was wondering if you think that this is best addressed with some sort of interventional clinical trial, randomized and so on, and whether this group that's formed around this interest might be willing to do that and consider that.
That is always the ideal, to be able to really compare real-time and control for all these different baseline characteristics. The problem with that is these are still really big morbid procedures, and the question of randomizing patients to a delayed pouch versus an immediate pouch, when we know that a delayed pouch might confer better outcomes for sicker patients, might have some ethical things to consider with that approach. But you're right, I think in a perfect world, I would definitely try to run a trial, especially with all these collaborators on board. Yeah.
So just one question. Since there is wide variation in surgical approaches and also in terms of the patients and when they present for the surgery, do you have data on the time spent in ulcerative colitis before surgery as a variable affecting the outcome?
We do not, unfortunately. The best surrogate for that is whether or not patients are on stronger and stronger medications. So whether or not they showed up with biologics or immune modulator use. And those are things that we actually did control for. I didn't put it in the slides, but those are included in our adjusted analysis. So that's the best surrogate we have right now, because unfortunately NSQIP, and by definition our database doesn't track patients until they really present for surgery. But that's something to consider if as we flesh out this database. Yeah.
Does NSQIP have information on time of onset of ulcerative colitis, and to the first diagnosis of ulcerative colitis will give you a time interval?
To my knowledge, they do not at the moment. So we rely on post-operative diagnosis codes. Yeah, so that's one of the big limitations. Yeah. So definitely time. A time that a patient spent in having ulcerative colitis can be a big confounder in this kind of analysis. But again, the best surrogate we have is their immunosuppression load. Yeah. Yeah.
Can you just, what I took home in there was that the centers that have higher volumes were more likely to have delayed surgery, right, or delayed pouch. And can you explain that again, why you're thinking?
Yeah, sure. So, two things that I'm thinking about. So, one could be definitely experience. Higher volume centers might be more likely to adopt a more novel approach. Relatively speaking, the delayed pouch approach is a little newer than the immediate pouch approach, which was done when there were less, where their medications weren't as strong and patients were actually presenting healthier. The second thing, though, is these higher volume centers might represent, in my mind, tertiary care centers where they're just seeing a higher acuity of patients or a more complicated patient than they would say at like a community center. Yeah.
Oh, I see. Okay.
Could be they're also too busy.
Could be that too, yeah. There it is.
Could you look at that through the complication rate, or is there, in your data, can you look at what the characteristics are of the patients in the high volume center compared to others?
Oh, I could do that, but it's unfortunately I didn't put that in the slides. But that's definitely something to keep in mind. Yeah, thank you.
All right.
Thank you.